presenters, there will be an award at the end of this for the best presentation. So let's go ahead and, if you can pop my talk. So this is our last talk of the day. Thanks for staying and listening. I'm going to be speaking to you wearing a different hat. I'm going to be speaking to you from the perspective of the Pennsylvania Orthopaedic Society. I serve as the vice president currently of the Ortho Society. But I know there's a lot of people from out of town here, and the information here is transferable really to anywhere in the States, frankly. And what I want to do is, so disclosures, the only thing relevant is my POS involvement. So what I really want to do here is talk about three things. One, to talk a little about what is this crisis or epidemic, what does that mean exactly, what's contributing to it, and what are some strategies as healthcare providers that we can utilize to help combat it, and really all from our perspective, if you will. So just a mental poll. I don't need a show of hands, but those of you who are prescribers, I'd ask yourself to think, do you have a number of pills, of painkillers that you routinely prescribe after various surgeries? And I know I had a number. I used that number for many, many years. And ask yourself, does that number change, and why does it change? So just keep that in the back of your mind, and we'll talk more about that as we go on. So the takeaway points, it's always good to start at the end of a talk at the very beginning, and there's a couple takeaway points I want you guys to have, and we're going to start with that. One is, the opioid epidemic is a multifactorial problem. We keep talking about it from a physician perspective, but there's a lot of perspectives here. And one is, and the most important is the patient perspective, the patient factor. They have a lot of responsibility here, people do. And something that they need to take very seriously, and they're contributing to it as well through a number of ways, and we'll talk about that. There's the influence of the pharmaceutical industry, and they've had a lot of culpability in this circumstance that we're in as well. There are regulatory initiatives, be it from the federal government, be it from the state government, now from pharmacies itself in terms of how we're prescribing, as well as from different health and hospital boards. And lastly, physician considerations. What are the habits of physicians and prescribers, tendencies, biases that drive how they prescribe? And one more thing, I always want to mention this because I think it's important that when we talk about opioids, I'm not trying to vilify it. We can't do the work that we do without opioids. It allows us to do amazing work. It allows us to do the surgeries and treat the injuries that we're able to do, and without them, that wouldn't be possible. So we have to, the goal is not to vilify, but to look at what we're doing wrong, or what can we do better. And lastly, in terms of takeaway points, I want you to remember this. Don't prescribe opioids to your outlier opioid needs. Prescribe an amount for your typical patient's consumption. So if most of your patients need typically about 10 pills, and occasionally one needs 40 to 50, don't give everyone 40 to 50, and I'll expand upon that. All right, so let's look at the U.S. So a statistic that's often mentioned is this whole statistic of consumption, so which includes that the U.S. represents about 5% of the world's population, but consumes about 80% of the world's opioid consumption. To be fair, this is about oral opioid consumption. So not all. There's a lot of opioids used in other mechanisms such as anesthesia, but in terms of oral opioid consumption and certain medications such as Vicodin or hydrocodone, we consume 99% of it. So that's a good amount that we consume. And if you extrapolate that further, a recent survey looking at heroin abusers stated that they started their addiction, if you will, with prescription opioids and ultimately turned to heroin because it was cheaper and easier to get. So it's often the gateway to bigger problems, if you will. If you look at prescribing patterns, it's been on a steady incline. And I circled about the point where the fifth vital sign came into play. That's often indicated as a cause of the increased opioid prescribing, opioid consumption, opioid demands. But really, if you look at this graph and zoom out, it's really been going on for quite a long time, and only recently started to level off. So it's not just related to the fifth vital sign, but obviously that's contributed. But it's been going up for quite a long time. This is probably the next couple of slides is really what makes this important. If you look at overdose-related deaths from drugs, it's opioid-related drugs that's really caused, that's steadily increased. We're up to about 15,000 opioid-related overdose drugs per year. If you look at marijuana, it's essentially zero. Heroin and cocaine has been pretty steady. and opioids are 2 to 3 times more than heroin and cocaine individually. So we're at about 15,000 deaths per year, and about 3 out of 4 of all drug overdose-related deaths. So it's not a minor thing. This is definitely a real issue. And these numbers vary a little bit from state to state, but Pennsylvania is pretty close in terms of percentages to the national average. So this is a study I think that really helps encapsulate and summarize the fundamental problem that's going on here. So this is a paper published in JAMA Surgery last year. And the authors looked at all types of surgeries performed, so not just orthopedics, general surgery, OB, urology, orthopedics, et cetera. And they looked at 36,000 opioid-naive patients who were not taking any opioids before their surgeries, and then they were given opioids after surgery. And they found that 6% of their patients were still consuming opioids 6 months after surgery. So that implies, doesn't prove, but that implies a 6% addiction rate. And this was the same irrespective, this was the same irrespective of the surgery performed being a major surgery or a minor surgery, a big or a small surgery. And it was pretty consistent across that. So 6%, so that's the number that you have to think about, that are 6% of my patients going on to opioid addiction based upon your prescriptions. Where are patients getting opioids from? So here's the breakdown of where people who abuse opioids, where they get them from. 70% get them from friends and family, and 20% get them from doctors. So you may say that's not too bad, 20% from doctors, but the problem is the friends and families are getting them from doctors too. So ultimately, they're either coming 20% directly from physicians or 70% indirectly from physicians, and that's what's going on here. And this is the concept of what's known as diversion. Diversion means that you receive opioids for a medical reason, and whatever is left over, you then divert to either sale or abuse or what have you. And that's the issue with diversion. So that's why the numbers that we prescribe are so relevant. So how do orthopedic surgeons fare in this? So here are the most common causes for receiving opioids prescriptions. If you'll notice that trauma or injuries and back pain are the 2 most common reasons, followed by cancer. So we're right in the middle of that in terms of who's responsible for prescribing. And there's been more and more attention turned towards us in terms of possibly being kind of in the center of this epidemic in terms of how much we prescribe. We tend to prescribe at a large number because of the nature of what we treat. We treat musculoskeletal injuries, and we then cause pain briefly after the various surgeries that we perform in musculoskeletal surgeries, and musculoskeletal injuries tend to be painful injuries and surgery. So that's kind of where we're at right now. So we are typically considered to be the 3rd or 4th largest prescriber of opioids in general, and the 1st or 2nd largest prescriber of opioids for acute pain. The alternative being chronic pain, which is such as for cancer treatment. So for acute pain, and we're getting increasingly negative press and pressure. So the question is, can we do better? So let's look at those things we want to talk about. So we want to talk about patient considerations, physician considerations, regulatory consideration, and then I'm going to end with, are there any better prescribing strategies that we can adopt? So let's look at it from the point of patient consideration. So the patients, like I said, are very much relevant in this. So we know a bunch of things. We know that patients that have been using opioids preoperatively for whatever reason tend to have higher pain and higher opioid needs and decreased clinical outcomes postoperatively. So that's a big red flag when a patient is requiring opioids preoperatively. We also know that people that have tough time managing stress, having anxiety, pain catastrophizing, other psychiatric conditions have a tendency to also demand more opioids after surgeries or injuries, and also tend to have lower outcomes. So these are some patient variables. There's also this concept of doctor shopping. A recent study looking at consumption using a prescription drug monitoring program, and I'm going to talk about that briefly, but basically some states, including Pennsylvania, have instituted prescription drug monitoring where providers can now look online. They can look up a person. They can say, okay, Saqib Rahman, how many prescriptions has he gotten, how many pills he's gotten, and who has he gotten them from. So you can actually really track in real time what people's consumption patterns are. And they found that that there's a good amount of what's called doctor shop. People are willing to go around and retrieve opioids at the same time from that's weird. I'm sorry. Look around for other providers to identify opioids. So what else do we know from that study? And this was actually published in the Academy Bulletin, that there are certain risk factors for opioid abuse amongst patients. So patients with lower educational levels, patients with lower socioeconomic status, patients with psychiatric conditions, patients with a history of substance abuse, and of course, patients with a history of prior or ongoing opioid use or dependency. Those are all risk factors for later abuse and dependency. So things that we need to take into consideration when prescribing. So what about some surgeon consideration? This is what kind of hits home a little bit with us, is that how are we doing? So there's been a number of studies recently that's been published, and this is one of the earlier ones, that's only a few years old, that looked at prescribing and consumption patterns, and this is after upper extremity surgery. And the authors found that they looked at about 250 patients undergoing various upper extremity surgeries, and they found that on average, their surgeons were prescribing them 30 opioid pills after surgery, which is a pretty common number. I can tell you anecdotally just from around, and I'm sure that number is familiar to many of you. But on average, patients were only consuming about 10 pills. So what that meant was that there's a large amount of opioids being prescribed that were going unused. And again, remember that concept of diversion. So extra pills can be abused. So if you prescribe extra low pressure, extra insulin, what have you, they're not going to be abused. But this has value both from an abuse perspective and a monetary perspective. And again, your patient may not directly be diverting or abusing, but others can who have access to those. And if you look at just this study by Rogers, they had 250 cases. If you use their numbers, and they said they prescribed on average 30 pills. So that means for this study alone, on average, they prescribed 7,500 pills, only 2,500 were used. So actually, just amongst these few authors in this short study period, 5,000 opioid pills were prescribed in that period that were unused and potentially available for diversion. So it's an important concept. This is a paper that we published in JBJS in 2016, looking at a larger cohort. We looked at about 1,500 cases and looking at opioid consumption patterns and prescribing patterns, and it consists of 9 surgeons, 1,500 patients, and we looked at what people were getting, using, and determining some rates. And our findings were actually very similar to that other study by Rogers et al. And what we found basically is on average, our docs were prescribing 25 pills. Our patients were consuming on average 8 pills for a similar utilization rate of about a third. So again, and we broke this down many which ways in terms of where the surgery was, how the surgery was performed. But again, it's a lot of pills that went unused. And we also informally surveyed our physicians as to why they were prescribing the numbers they were. And the reasons were very common and very consistent. They did not want to undertreat their patients. So if, they don't want their patients suffering at home on a weekend and they can't get a hold of you, so you want to make sure they have enough pills. Avoiding office calls in the middle of the day and needing more prescriptions, that can be very disruptive, especially since you can't call in most opioids. It becomes a process to get it to them. Avoiding complaints either directly or online, and also a little bit of practice routine. You have a number that you tend to prescribe, and you just keep prescribing that number. But one of the things that we also found is that the surgeons themselves were very surprised as to the number that their patients were consuming. So there's definitely a component of trying to understand what it is, what is the amount that your patients may need. And again, it's very specific to where you practice, what kind of patients you deal with, or what type of injuries or condition you treat with. It's not across the board. It's different, but you should extrapolate and make it specific to your area, your type of surgery, your type of pathology to treat. Again, getting back to this concept of diversion. So in our study alone of 1,500 cases over, I think, about 6 months or so, if you look at what we prescribed and what was claimed to be consumed, in theory, about 24,000 unused opioid pills were prescribed by us. It's a pretty damning number, in my opinion. And that's just 9 guys in one town over 6 months. So you can just keep extrapolating that out to the whole town, the whole state, the whole country, not just orthopods. You add general surgeons, add other docs to it, and you keep adding. That number starts to really grow, and you can see why that there could be a potential for abuse. So let's shift gears here a little bit, and let's look at some regulatory or political considerations as well. There's been a lot of discussion at the federal level. Really, nothing's happened, for better or for worse. Former President Obama wanted money for the opioid crisis. It was not passed. He had some ideas about managing it. Current President Trump proposed an opioid crisis strategy where he's committed $6 billion to address, or consisting of 3 strategies, which consist of reducing opioid use via an ad campaign, stiffer penalties for drug traffickers, including the death penalty, and expanding access to opiate addiction treatment. So that's been earmarked. I don't believe it's been implemented, but that's what he's put forth as well. You may, if you practice in Pennsylvania, even as a resident, you would have received this letter about a year or two ago from the last Surgeon General who made a personal plea to be critical about how we all prescribe opioids, and he asked for 3 voluntary steps to be taken relative to the opioid epidemic. He stated, number 1, consider sharpening your opioid prescribing habits. Number 2, connect patients who have opioid abuse problems to those who can help them. And number 3, to consider changing the way that we look at opioid abuse, so not as a moral failure or an individual problem, but actually as a health condition, so we can be more objective and direct about its management. In this state, Governor Wolf, who's our current governor, signed into law a couple years ago an opioid bill that limited emergency room prescriptions of opioids to no more than 7 days, implemented the physician drug monitoring program that now allows us to, and actually are required to check patients' opioid usage patterns before prescribing, requiring medical students to teach medical students about opioid prescribing strategies, and encourage physicians to take CMEs related to opioids. So this has been put forth as more. I can tell you that there's about over 300 pieces of legislation in the House and the state legislature touching on various parts of this and in different directions, and they're going to be vetted through the legislature, and we'll see what comes to fruition amongst that. But there's a lot of energy and concern on this topic in Harrisburg. I mentioned a couple times the physician drug monitoring program. And this basically, again, you can check to see what's going on. One of the things, and this is active, this is live. One of the things that we've been advocating for, what we've been advocating for is e-prescribing. One of the reasons why physicians tend to prescribe higher numbers is for the practical reason that if your patient needs more, you can't physically get them more because you need a paper prescription. So if it's off hours, if it's weekends, et cetera, they're unable to get it, so there's a tendency to give more. If prescriptions could be called in electronically, it would do away with that problem of having to have a paper prescription. Moreover, it would take away the issue in terms of lying and manipulating. So I lost my prescription, or my dog ate my prescription, or those type of things go away. Now you can directly prescribe. So this is being rolled out on a limited basis and something that we've been advocating for. It just passed the legislatures, both houses, recently, and it's expected to be signed, and it's going to be rolled out. It's already been rolled out on a trial basis in certain centers. So in terms of the state societies, there's been a few things that's been going on as well. The Pennsylvania Medical Society has adopted the CDC guidelines for chronic pain, and I won't get into that, but the real issue for us in the room is acute pain management. So the PA Ortho Society came up with 6 acute pain management strategies, and it's worth just spending half a second to talk about them. They're basically 6 very simple things. One is encourage the use of non-opioids whenever possible. So it's reflexive that we have to give an opioid after a procedure. This is a uniquely American characteristic that you have to have a surgery and you have to have an opioid. I dare anyone to send a patient home from the operating room, recovery room without an opioid prescription. 7 nurses will come charging at you and say, where's the painkiller? But that's only in America. Other places, patients routinely are managed with non-opioids out of the OR. So again, this is something that we have to challenge and also encourage our patients at home, like, hey, I'm giving you a prescription for a painkiller. You don't got to take it. You can take other things first and use this as needed. Identify risk factors for abuse and addiction. I mentioned some of those variables now, but again, lower socioeconomic status, lower level education, history of substance abuse, history of psychiatric conditions. If you know those things are going on, and oftentimes you just have a gut sense about people like, okay, this is going to be a problem patient, be mindful of that and react accordingly. Number 3, define the duration of opioid therapy. This is actually a very non-intuitive but effective strategy. Tell patients that with, you're having your ankle repaired, you'll typically need a painkiller for 1 to 3 days for this. If you define the period of time, then people's expectations become set based upon that. Number 4 is knowing your patient's prescription history. This has become easier with the PDMP. Engaging other doctors. So if there's a patient who we know through the PDMP is getting opioids through a number of venues or providers, then to try to corral them in and say, okay, who's going to be the provider, and dropping a call to so-and-so's office and say, hey, we share this patient in common, and are you going to manage this person's pain, or am I going to do it? So they're not receiving opiates from both parties. All right, so let's get to and this is what I'm going to end on, is what should we do? There some prescribing strategies that we can consider going forward. So again, so basic things is, firstly, if just from this talk, if you just give it a little bit of thought and look a little bit more critically about what you prescribed, then I think it's been effective. Consider some of our recommendations that we've defined, and consider counseling strategies, perioperative pain strategies, and postoperative prescribing strategies. So let's look at each of these. So again, the POS recommendations, like I mentioned, I won't review them again. Number 3 is consider preoperative opioid counseling. So this is something that's interesting. We study this, and we found that when you actually proactively educate your patients on their postoperative pain experience, anticipated postoperative pain experience, also instruct them on the risks and benefits of opioids, instruct them on smart pain management strategies for after surgery, they actually tend to consume less opioids just by being preemptive about it. And this is something that we rolled out on a limited scale, and now we're rolling out in a larger scale. And in my own practice, I give people an iPad before every surgery that goes over, it's about a 10-minute iPad video that goes over a number of things, including in detail pain management, but also simple things like how do you manage your dressings, is swelling or normal or not, the questions we get all over and over again, how much of a fever is a problem. But within that, you can also talk about opioids in some detail. What are some perioperative pain strategies? This is a huge talk and multiple talks in and of itself. I'm not going to get into it. But again, the point is there's a lot of perioperative strategies. We had a resident presentation on blocks earlier. That's one common modality. But there's different types of medication cocktails that you can get. The TLC cocktail people use for joint and spine surgery, for example. There's lots of different ways. But again, look at what you do in terms of your own practice and see what are ways that I can adopt perioperative strategies that works. And lastly, consider tighter opioid prescribing. So just look at what you do, and it's different for everybody. And I don't recommend anyone prescribe what I prescribe necessarily. Ask your patients, hey, what did you need for that hip replacement? What did you need after that knee scope? And get a sense of what they're getting. And it's surprising as you really get into it. The numbers may really kind of surprise you. So you don't need to prescribe to the outliers. You can prescribe to the average and say, okay, well, I don't need to prescribe everyone 40 if people typically take 15 or 10 pills. Because remember the whole issue with diversion, those pills are there for potential abuse. In my own practice, I've dropped it down really low in terms of what I give people. The really common, easy, soft tissue surgeries that hand surgeons do a lot of, such as carpals and triggers, I just give them 5 pills. Everyone gets 5 pills. I used to give 30 pills, just give everyone 5 pills. And I can tell you, you can ask my assistant, in a month we might get 1 call for a refill or for more. And so again, looking at what we do and preparing people for it and what have you. Now that number may be different for where you work and who you prescribe and what procedures or injuries you manage. But again, titrate that to where you're going to live in terms of what's best for your respective community. And again, prescribe to the outlier. Don't just prescribe to the outlier, just prescribe to the average. So again, takeaway points, consider these things when you're prescribing opioids, and be more cognizant of it, because people are watching what we're doing. So it's not only the right thing to do, but also people are beginning to watch as well. So I'll leave you with this paragraph from that same Surgeon General's letter, because I think it was pretty, I think it hit home in terms of what this means. So he writes, and I quote, "Years from now, I want us to look back and know that in the face of a crisis that threatened our nation, it was our profession that stepped up and led the way. I know we can succeed because healthcare is more than an occupation to us. It is a calling rooted in empathy, science, and service to humanity. These values unite us. They remain our greatest strengths." So I think that kind of sums up the spirit of this, and hopefully you found that helpful. Thank you.